In this screencast, we will examine respiratory disorders and the developmental aspects of the respiratory system. This information will be found in Chapter 13 of your textbook. The following are the objectives of the screencast. Describe chronic obstructive pulmonary disease and compare and contrast the most common forms, chronic bronchitis and emphysema. Identify the cause of most lung cancers and the 5-year survival rate. Describe the cause and treatment of infant respiratory distress syndrome, and describe age-related changes in the respiratory system. Chronic obstructive pulmonary disease, COPD, is a group of diseases where there is chronic obstruction of airflow and a reduction in pulmonary ventilation. It is a major cause of disease and disability in the United States. The major forms of COPD are chronic bronchitis and emphysema, although there are others. All COPDs have the following features. In almost all cases, there's a history of smoking in the patient's background, or they worked in a situation where they were exposed to respiratory toxins. Patients with COPD typically exhibit air hunger, also called dyspnea, and that becomes progressively worse with time. Coughing and frequent pulmonary infections are quite common with people with COPDs. Features of the disease are as follows. Patients will tend to have high levels of carbon dioxide in their blood, leading to respiratory acidosis. That is, a lack of ventilation and gas exchange, leading to high levels of carbon dioxide, which then cause low blood pH. Patients also tend to be hypoxic, meaning they will have lower than normal levels of oxygen in their blood and tissues. If the patient doesn't die from other causes, eventually the disease will progress to its ultimate conclusion, which is respiratory failure. Although there are other COPDs, the most common are chronic bronchitis and emphysema, and those are the two types that I am going to discuss now. Itis means inflammation. So bronchitis is inflammation of the bronchial tubes. Specifically, the mucosa of the lower respiratory passages become chronically inflamed. And when we say chronically inflamed, we generally mean inflammation that is in excess of 3 months. You may, of course, have had bronchitis at some point in your lives, but that's not chronic bronchitis. That's acute bronchitis, typically caused by a bacterium or in some cases virus. This is chronic bronchitis, which for the most part you will have. Once you have it, you'll have for the rest of your life. This chronic inflammation is usually caused by smoking or some kind of chemical fumes, dust, or other substances that causes this chronic inflammatory response. This continuous inflammatory response leads to destruction of those pseudostratified columnar epithelial cells containing cilia, and they're replaced with stratified squamous epithelial cells, which are not ciliated. As a result, mucus tends to pool in the lower respiratory tract, and this interferes with pulmonary ventilation and gas exchange. Individuals with chronic bronchitis will tend to have a deep cough that brings up sputum, which is a mixture of mucus and cellular debris, cells that have been destroyed as a result of this chronic inflammation. Development of hypoxia and the associated cyanosis tend to occur relatively early in chronic bronchitis, and therefore Patients with chronic bronchitis are often referred to as blue bloaters because they have air hunger, and their skin will tend to have a bluish tint to it due to the cyanosis. Emphysema results from fibrosis of the lungs. If you recall, fibrosis is the replacement of destroyed tissue with scar tissue, dense connective tissue. And as you can imagine, if you replace normal lung tissue with dense connective tissue, it's different in structure, and therefore it's not going to perform the same. If we look specifically at someone who has a normal alveolar sac, notice that you can see the individual alveoli. There are walls between the individual alveoli, and those walls provide the surface area for external respiration, gas exchange between the air of the alveoli and the pulmonary capillaries. Let's contrast that with someone with emphysema. Notice that those walls between the alveoli are pretty much destroyed and gone. It's as though the individual alveoli have sort of merged together. That's a significant decrease in surface area. And the result is going to be a significant decrease in gas exchange between the air of the alveoli and the blood of the pulmonary capillaries. And this has been due to repeated damage and repair by toxins that have been inhaled into the lungs. There is also a general loss of elasticity of the lungs. I want you to think of your lung tissue like a rubber band. When you inhale, you pull on the rubber band, and then as you exhale and relax, the rubber band's elasticity causes it to rebound. Fibrosis of the lungs destroys the elastic tissue and therefore ability of the lungs to recoil. So what tends to happen is after inhalation, the bronchioles collapse upon expiration. You don't get your normal rebounding of lung tissue, and so air gets trapped in the lungs. And individuals with emphysema literally expend a great deal of energy just trying to exhale. Typically, a human uses less than 3% of their metabolic rate to breathe. Patients with emphysema may use 20% of their basic metabolic rate just to inhale and especially exhale. Patients with emphysema, because of the air trapping in their lungs, tend to have overinflated lungs. This leads to a permanent barrel chest, but one of the benefits of this, I suppose, is it does lead to greater efficiency of gas exchange across the respiratory membrane. So we don't see the cyanosis in individuals with emphysema until later on in the disease, but we still have the air hunger, and therefore patients with emphysema tend to be referred to as pink puffers as opposed to the blue bloaters with chronic bronchitis. This figure comes from your book, and I'm going to use it to summarize COPD. COPD is caused by long-term exposure to respiratory toxins such as tobacco smoke or air pollution. This can lead to, in the case of chronic This presents as excessive mucus production. This leads to airway trapping, air hunger, and frequent infections, and ultimately will lead to respiratory infection. With emphysema, we have replacement of normal lung tissue with scar tissue or fibrosis. This leads to destruction of the alveolar walls, leading to a reduction in the surface area across which external respiration occurs, leading to air trapping, dyspnea, and frequent infections. And as with chronic bronchitis, if the patient doesn't die of some other cause, respiratory failure is inevitable. Lung cancer is the leading cause of cancer deaths in the United States. If we were to take the numbers of people who died of breast cancer, prostate cancer, and colorectal cancer and combine them, it would still be less than the number of people in the United States who die from lung cancer. And most importantly, in most cases, lung cancer can be avoided altogether. 90% of all lung cancer is due to exposure to carcinogens in cigarette smoke. And even though we have better therapies than we've ever had with respect to treating lung cancer, the 5-year survival rate after diagnosis is still only 17%. In other words, of the 100 people that were diagnosed with lung cancer 5 years ago, only 17 of those 100 are alive today. Lungs really have no use prior to birth. Fetal lungs are filled with fluid. At birth, once the fluid is drained from the respiratory tract, the baby takes his or her first breath, and then the lungs are functioning. However, it's another 2 weeks until the lungs are fully inflated. Also, if you recall, I mentioned when we were discussing the respiratory membrane that there are cells that produce a surfactant that lowers surface tension so that the lungs don't collapse when we exhale. If our lungs collapse every time we exhaled, we would have to expend an enormous amount of energy reinflating them. Think of when you blow up a balloon. The most difficult part of that process is getting the balloon started. So we don't want our lungs, our alveoli, to collapse every time we exhale. That surfactant is produced during the latter portion of fetal development. Specifically, it's not present to about 28 to 30 weeks of development. That corresponds to about 7 months of gestation. So a premature infant born before about 7 months of gestation, or born to a diabetic mother where there is impairment in development, might not produce enough surfactant, or perhaps their lungs don't produce any surfactant at all. And what that leads to is infant respiratory distress syndrome, where the infant's alveoli collapse between breaths. And this causes the infant to have to expend a lot of energy when breathing. With the infant struggling to reinflate the alveoli, this leads to complications that ultimately puts the infant's life in jeopardy. In fact, infant respiratory distress syndrome is the leading cause of death for infants less than 1 month of age. It accounts for over 20,000 newborn deaths annually in the United States. Treatment is typically using a medical device to provide sustained positive pressure on the lungs so that the lungs don't collapse between expiration. And they'll stay on that medical device until there's enough endogenous production of surfactant to prevent collapsing of the lungs between breaths. Let's look at how respiration rates change with age. Newborns have the highest respiration rates, somewhere between 40 and 80 breaths per minute. When they are infants, that's around 2 months, respiration rate has declined to about 30 respirations per minute. By age 5, it's down to 25. And then between age 5 and when one is an adult, and we're going to consider an adult about 18, respiration rate is down to somewhere between 12 and 18 respirations per minute. And then after that, respiration rate tends to stay relatively stable until you hit old age, around 70 plus, and then we see a slight uptick in respiration rates. You may find it interesting to learn that lungs continue to develop from birth throughout your childhood and even on into your young adulthood. That is your mid to late teenage years. What this means is if you start smoking early, it can actually arrest or stop the development of your lungs. So you can literally retard the development of your lung capacity by starting to smoke in your early teens. What are other age effects that we see on our respiratory system? Elasticity of the lungs tends to decrease. This leads to a decrease in our vital capacity. By the time we are age 70, we could have lost a third of our vital capacity. Carbon dioxide levels tend to rise and blood oxygen levels tend to fall. And we appear to become less sensitive to increasing levels of carbon dioxide. And this might lead to a condition called sleep apnea. Also, those macrophages that are in our respiratory membranes that are supposed to destroy microorganisms, dead cells, etc., they don't respond as quickly to infection, and so we tend to be a little more susceptible to respiratory diseases in old age. As we are now at the end of the screencast, let's do a recap of our objectives. Describe COPD and compare and contrast the most common forms, chronic bronchitis and emphysema. Identify the cause of most lung cancers and the 5-year survival rate. Describe the cause and treatment of infant respiratory distress syndrome. Describe age-related changes in the respiratory system. This marks the end of our screencasts on the respiratory system. You may now officially breathe easier.